you haven't met him before. He's an orthopedic surgeon working in sports with major interest in knee and shoulder injuries. So it's a pleasure to welcome you to the Auckland Sports Medicine Group, Mike. I'm looking forward to your registration arriving in the mail and talking to us today.
Thank you for inviting me to speak. Unfortunately, I do have to talk about label pathology, and it's something that is a bit of a confusing area really for everyone involved, and it's evolving and changes year by year. So what we'll do is we'll run through, in particular Mark asked me to speak about SLAP tears, and so we'll run through a bit of the history, what's been done in the past and where we might be heading with them. Before I move on, I want to reiterate what Graham says. To me as a surgeon, no operation I ever do is going to work unless the shoulder is balanced with the periscaping stabilizer. So it's critical pre-operatively and post-operatively. So it was a fantastic last slide. So 22 years ago, SLAP tears kind of exploded into the shoulder. They were originally described earlier in 1985 by a guy called Andrews, but were kind of left for another 5 years until Schneider and his group did a retrospective study of their cases and coined the term SLAP, which means superior labrum anterior posterior. Kind of a confusing term, but effectively it's talking about the top of the joint where the bicep anchor inserts and the labrum immediately adjacent to it, anterior and posterior to it. And so what Schneider did was that they did a retrospective review of 700 cases. They coined the term SLAP. They looked at all their mechanisms and they found there were only 23 patients in that entire group who had this injury, so it's not a high percentage of cases. They looked at the mechanisms, most were from a fall onto an outstretched arm, and the symptoms they presented with predominantly were pain, especially pain with overhead activities and above shoulder activities, and in particular in athletes who are in those fields. And also a significant number had a mechanical catching or popping in the shoulder associated with pain and associated with specific movement. So we're not talking about pain at rest, we're talking about pain that's specific to a motion or a mechanism. So they came up with a classification and they described 4 original types. So type 1 on the left there is just fraying at the superior biceps anchor. And then the type 2, where the biceps anchor is torn, but the remainder of the capsule is intact, labrum is intact, sorry. Then a type 3, where you have a bucket handle tear of the superior labrum, but the biceps anchor is completely stable. And then the type 4, where you have a bucket handle tear, and the tear extends into the biceps, so the biceps compromised. And so those are the 4 types that they originally identified, and they proposed treatment options for them. So for a type 1, just debriding the frayed area, you don't need to do anything about the biceps, it's still stable. The type 2 needed to be fixed, is what was their impression. The type 3 just needed the bucket handle component taking out and debriding. And a type 4 came a decision where you made a call. The bucket handle needed to be removed, it's too big to stabilise. And then a decision made as to how much of the biceps was involved. And so they came up with less than 50%, you can preserve it, stabilise it. More than 50%, you should cut it, get rid of it, tendinize it. So, 22 years later, where are we at? And how much further we got with these SLAP injuries? Well, we've come up with a few more types. So like anything, once someone's described something, they give it a roll on. So now we've got type 5, which is a superior labral detachment associated with anterior instability. So the whole anterior capsule is torn off. You've got a type 6, where there's a free fragment of the anterior superior labrum associated with instability. We keep going, type 7, with a superior labral detachment with an extension into the middle glenohumeral ligament. A type 8, where it's detached from the top and extends posteriorly. Type 9, circumferential complete release of the labrum. And a 10, and it just keeps going and going and going. So obviously, whenever you see a classification system that's got this many things in it, there's a lot of confusion, okay? And no one's really sure what's going on, which ones are important, which ones aren't important. The simple way to think of them is to think of the SLAPs as the 4 original types that are described. The remainder, 5 and upwards, are associated with instability. So they're more pan-labral or total labral injuries. So when we talk about SLAPs, we tend to be talking about that original 4 groups. But people have even tried to be describing up to 15 types, which is just getting ridiculous. So the real problem is the type 2 SLAP. And so when you see the debate in the literature and the debate amongst surgeons and people is what to do with this type 2 SLAP. The type 2 SLAP is essentially the biceps anchor is not subluxing into the joint, but the attachment is clearly abnormal. There's fraying, or there's some element of instability, or there's a meniscal component to the superior labrum, which is over the edge and into the superior aspect of the glenoid. So that's where the confusion is, that's where the debate is. The remainder of everyone's pretty happy what we need to do with it. So, first of all, how do we examine for a SLAP? Well, there are multiple studies, there's multiple tests. O'Brien's and the biceps load test, in particular the biceps load 2 has probably been shown to be the best. They all have a high sensitivity with a lot of tests around the shoulder, so people who have sore shoulders have positive tests. Okay? But they're very poorly specific. Okay? So as you know from examining shoulder patients, there's lots of tests that cause pain. They don't always point to one particular thing. They're not specific for a SLAP injury. So they have high variability and low reproducibility. So biceps tendons tests haven't fared well in the current literature when people have gone and scientifically looked at them. And so more people talk about now is doing a number of tests and a shoulder becomes suspicious. It's a suspicious shoulder for a SLAP injury. You can't diagnose it with an examination. Okay? And obviously we've jumped over the history, but that's critical as we emphasised in the first slide. It's not a general pain, it's a pain that's specific with movement, often with a catching, popping, or mechanical symptoms within the shoulder. Imaging for SLAP, well, the MR arthrogram is the way to go, and this shows a SLAP lesion on the coronal slice, and what we're looking at is we haven't got the biceps coming across, but we've a slice further posterior to that, and you can see this fluid tracking up underneath the biceps labrum and anchor. And the thing to look for is there's a huge amount of anatomical variability in this area, such to the point where when MR first started, this was basically a no-go zone. Clyde Helms, who basically wrote the textbook from North Carolina on MRI of the shoulder, basically says from 12 o'clock through to 2 o'clock on the anterosuperior labrum is a no-call area. He can't tell you what's going on. And he's the guy that wrote the textbook. And what they do is that they have a system that nowhere else is reproduced. Every week they sit down with the sports surgeons and the shoulder surgeons, and they go through every case that's been operated on. They look at the imaging, and they look at what the intraoperative findings were, and they match them up. And when they say it's a no-go zone, it just tells you how difficult it is an area to call. So it was considered that arthroscopy was the gold standard. Now, just before we move on, the one thing that's consistent with an MR SLAP lesion is when you see fluid tracking laterally within the labrum, that's a SLAP tear. Okay, so that's something everyone agrees with. The difficulty is that there's a superior labral or a sublabral recess that comes over the superior portion of the glenoid, which makes it difficult. And so the biceps has a huge variability in how it inserts. It inserts partially into the supraglenoid tubercle and partly into the top of the glenoid, and there's variation. Some people are 80% off the supraglenoid tubercle, some are 50-50, some are 90-10, and so everyone's different. And that's what makes it such a difficult area to call. However, in a situation like this, where you see the fluid tracking laterally, it's a SLAP tear, and especially with this is a paralabral cyst. Okay, and so the only way you get paralabral cysts is with tears. It's like a meniscal cyst. It's almost pathognomonic for a meniscal tear or a labral tear in the shoulder. So arthroscopy for SLAP is the gold standard. That's what everyone tells us. Well, is it really? And so what the American Arthroscopic Association did was they did a mail out to all their experienced shoulder surgeons with a whole lot of videos. So they sent out a number of videos for them to look at and comment on and answer a question as to what they thought the diagnosis was looking at this SLAP lesion and how they would treat it. And what they found was there is a huge inter-observer variability amongst the surgeons. So what I think is a SLAP 2, someone else thinks a 3 or a 4 or a 1. So less than 50%, when they looked at the videos, agreed on a diagnosis and the treatment. Interestingly, it was almost a reverse situation. If you went and said to the surgeons that this is a SLAC2 lesion, how are you going to treat it? Then everyone agreed on how to treat them. The problem is making the diagnosis in the first place. And so arthroscopy is difficult to decide what's going on. And why is that? Well, there's all these normal variations like we've alluded to. So just looking purely at the origin of the biceps, this is a good anatomical study which shows that the biceps can come completely from the posterior labrum. It can be posterior labrum dominant, it can be 50-50, or it can be anterior labrum dominant. Okay, and these are all normal anatomical variations, and that's where the confusion comes in, is if you go in there and look, you need to make a decision whether this is a normal anatomical variant or whether it truly represents a SLAC lesion. So a SLAC repair, so what do we do? So this is a SLAC injury on the left here, so it's probably a 2, you can see all the frame underneath the biceps anchor. But you can see also that the biceps is still intact and it's still solid and not subluxable into the joint because the main portion back onto the supraglenoid tubercle back here is intact. And what we do is we stabilise them, we go in and put anchors and suture them. And so this is a sequence of the events, and so you can see we get a shaper in, we burr up the top of the glenoid to create some bleeding bone. So our probe and get the anchor going in, and then we suture around both sides of the biceps and secure it onto the glenoid so there's no peel back. So you can imagine in that cocked position with this kind of picture as you go back, is that biceps going to peel back off the glenoid, and that's the hypothesis as to why it causes pain and discomfort as you're peeling it back in a cocked position. Obviously, once we've stabilised it, it's stuck down there, it's not going to peel back, at least that's the theory. Now that can either be a good thing or it can be a bad thing, because obviously we know some of them are designed to peel back because that's the way people are built. So what's the evidence? So when we go to the literature, there's no level 1 or level 2 publications. Okay, so you need to bear that in mind. Almost all of it is level 4, which is case series or cohort series of people's experience of what they've done, with no control group associated. The publication, you look back at the history of them over the last 20 years, outline a history of the SLAC. So first of all, we're just discovering them, and so most of the papers are focused on just debriding the SLAC lesions. Okay. Then we got onto the idea of repairing them and fixing them, so there's a whole big group that have gone through and repaired the biceps anchor. And then more recently, people are saying, well, the results of that aren't so great, what if we just chop it and tenadese it? So that's where things are starting to move now. So what's the interesting? Well, it's looking after sports, when you want to know how many of them get back to playing, how many get back to their activities when they've had this injury. So this is one of the few papers that have actually looked at that. And they looked at all literature and pulled down 14 studies that were appropriate, 506 patients. So they quoted 83% good to excellent results. But when you actually break it down, only 73% of people returned to their previous level of play, and only 63% of overhead athletes returned to their previous level of play. And that's not very good, especially when that's the primary group that you're trying to treat. So that's, we've still got a lot to learn about these. Why do we have such bad results? Well, this is there's a couple of papers in literature, we'll show you the next one as well, but the American, people are doing it too much. It's almost being over-diagnosed now, and that's the feeling, is that there's a lot of SLAC repairs being done that aren't required and aren't indicated. So one of the things the American surgeons do is that before they're cleared to finish their training as orthopedic surgeons, they have to present for the boards. And the boards is a year after they've started practice. So they have to come in at a year, sit down with some senior surgeons, and go through every case that they've done in the year, provide imaging, their outcomes, and their complications before they get tipped off to be free to go. And that all gets entered into a big database, and so people can go and look at it and look at regional variation from what people are doing and how they're treating things. And so what they did, they found nearly 5,000 SLAC repairs between 2004 and 2008, with an increasing incidence. So in 2004, they represented less than 9% of operations that shoulder sports surgeons were doing, whereas in 2008 now they're up to 12%. So more and more is being done. The mean age of males was quite scary, 36, plus or minus 13. So you're talking about fixing SLAC repairs in 50-year-olds. And a maximum, someone did one on an 85-year-old. I mean, you're kidding me. Similarly with the females, an 88-year-old. So you know, as we get older, we know all our tendons and things degenerate and get a bit frayed, but there's no way you can consider doing that, and yet this is what can skew some of the results, is that they're being inappropriately done in some groups. The mean follow-up in the study is short, because obviously these guys have only been practicing for 12 months, so they don't always have long-term follow-up. But the pain absent was only 26% of people reported absence of pain at 8 weeks. Now that's not that uncommon in shoulder injuries, but you would expect probably a little bit better in this type of injury, because it's not like a cuff repair where you're doing a huge amount of dissection or you're reattaching a tendon. It's all intra-articular, and in general, intra-articular arthroscopic operations people get over a lot quicker. But that's still significant. Functionally normal at 8 weeks, only 13% of them said they were functionally normal. But the interesting thing is the percentage of shoulder cases that people are reporting as slap repairs is 3 times what we would expect from the incidents in the literature. Okay, and so that's a concerning fact, because there's too many being done, and they're being done inappropriately. There's another paper basically reiterating the same thing, that it's an unnerving increase in the number being done, and also the age of the population that are being done in, which is probably inappropriate. So should we be operating at all? Well, there's almost no papers looking at non-operative management of slap lesions. This is the only one that's out there really, and it's a poor paper that you've got to go with what's been published. And so they recognised 371 patients from their practice, and they did a validated questionnaire that they mailed out. So mail surveys always have a poor response rate, okay, but it's better than nothing. So the responses they got, the ones that, so the non-operative treatment were anti-inflammatories, physio, the whole scapular stabilisation programs were to and posterior capsular stretching, because the baseball's massive in the States, and that's what a large number of especially their internal rotation contractures are. What they found was the patients who reported success with non-operative treatment, only 70% returned to pre-participation levels of sport, and only 66% of over-the athletes got back. Now, if you remember, that's almost exactly the same figures as following surgery. Okay. Of the patients that failed non-operative treatment, 50% went on to have an operation and ended up with, I'm sure, the same numbers. But basically 2/3 making it back and 1/3 not even getting back. So, this is obviously not the best. Is there any other options that we have? Well, biceps tenodesis is the next step people are talking about. So what a biceps tenodesis is that we cut the biceps at the top of the labrum, so when you've got your slap here, so this removes the tension force on the superior labrum, and then we plug it into the humerus, into its groove, okay, with a screw. So it fixes it there and secures it there. So when patients are doing a flexion with cotton position, the tension's going onto a screw and not onto the torn labrum. So are there any studies that look at this? Well, yeah, there's one that's kind of picked it all off, and it's from Pascal Boileau, who's one of the leading arthroscopic and shoulder surgeons in France, working out of Nice. And he's got a cohort study where he did 25 consecutive cases, and he had 10 that were repaired with a mean age of 37, and 15 that he tenodesed with a mean age of 52. 60% of the repairs were disappointed with their outcome. Okay? They had persistent pain and inability to return to sport, whereas 93% of the tenodesis group were satisfied with their outcome. What was the return to sport? Because that's ultimately what I'm interested in, what we're interested in. 87% of the tenodesis group were able to return to their previous level, so that's pretty high. 20% but only 20% of the repair group made it back to their previous level after the surgery. What are the weaknesses of the study? Well, one of the weaknesses is they're 2 different groups. Okay, so the tenodesis group were older patients who made the decision at that time based on age that he was happy to do tenodesis, whereas a younger athlete or person who wasn't quite so happy to be cutting a relatively normal biceps and doing tenodesis. So that's one of the weaknesses. So that they may be a different population group based on age. Small numbers is a weakness in terms of the power of the study, but it's also a positive in terms of SLAP tests because of the number of pathologies that can present also with SLAP tests. A lot of the studies have got stabilisations where they did a SLAP, small rotator cuff tear where they did a SLAP. So we're trying to weed those out and getting some information that is specific to the SLAP is difficult. whereas this was quite strict. They had no other pathology in the shoulder except a superior tear. So while the small numbers are bad for power, it's good that they're being that strict to give us some idea. So what we ultimately need the Norwegians are doing, so they're doing a randomised controlled trial looking at repair versus tenodesis in orphans. Okay? And that's ultimately what we want to know. We want to know that if you're 28, do you need a repair or tenodesis? And which one's going to give you the best outcome? And more importantly, which one's going to get you back to your open activities? Because the patients that I see on a day-to-day basis are fine. They don't have a problem. It's when they go for their badminton shot and the overhead slam, that's when they get their symptoms. And so as a functional day-to-day thing, it's not a big issue for them, but it's stopping them from doing the things they want to do. And so return to sport is the thing that I want to know about, as to which is the best for getting back there. So slack management. So where are we at the moment? And so it's a grey area. Okay. So you'll find surgeons who believe that you should never operate on a slack tear. Okay. Surgeons in this town, experienced shoulder surgeons who won't touch them. Okay, because they've had bad experience with patients who just move on guys pain. Then you'll go to places in the world where they operate on all of them, even ones that probably shouldn't be operated on. They'll stick an anchor and do it. And what's their motivation? Well, in some places it's financial, and in some places it's just what they believe works. Now, I'm kind of somewhere in the grey zone in here, probably more towards the never. I think it's a very specific indication for me. Patients have to really meet criteria. But like in shoulder surgery, one of his famous sayings, shoulder surgery is a lot like love. There is no never and there is no always. So for me, when I look at it, the history, I have to have a good history. Okay? You have to have a nice mechanism of injury, a specific event, and they have to have the mechanism at which they get their symptoms. So I want to hear a good story of the positional pain, of a clicking or a plunking in the shoulder. The pain can often be aching and portal localized. I don't mind that so much. But rest pain and things like that are things that I don't think I can help. Examination, like I said, there's a number of different tests. And like examining the shoulder, normally you need to do a lot, do multiple things to test the shoulder, and you end up with a shoulder that is suspicious for a slack tear. Then you go on to investigate it. I want to emphasise that always get plain x-rays of any shoulder that you're going to get, because you'll never know what shows up. We had one clinic that showed up a tumour that was being inappropriately managed, and so plain x-ray radiology before going on to more advanced imaging. And that's my general orthopaedic hat. But in terms of investigating for a slack, an MR arthrogram is the way to go. Okay? MR arthrogram is filling up the joint with omniopathy, which is a substance that lights up on the MR, it expands the capsule, and it gets into all the recesses and tears, so you can see what's going on, or at least have a more informed choice of what's going on. But as we know, MRI is not perfect either, but it can help build up the picture. Then the treatment, non-operative. Okay? Non-operative. They need to have gone through an extensive rehabilitation program, because you can't sit there and tell the patient you're going to get them back to playing with an operation. Okay? The small limited things we have with non-operative management shows the results may be pretty close to what operative is. And so for me, they have to have gone through, I'll send them away for another one, and they have to come back. They have to want the surgery basically, because it's not a home run. And that's the worst thing for me, is a non-home run operation. So I hate having patients come back and say, my shoulder's no better, because it's no good for them, it's no good for me. So when they do come to operative, and this is where it becomes, no one's quite sure what we should be doing, but in general, I think that patients that are under the age of 30 are ones that I'm more happy repairing and having a go at, not so much having a go at, having a giving the biceps a chance to heal and see if that improves their symptoms, because I do struggle to go in there and say, no, mine a bit of fraying, cutting what is relatively a normal looking biceps. I still struggle with that. And a young athlete, the biceps are probably meant to be out there for a reason. And so I'm happier to repair, knowing that I can come back later and cut it and these are later. It doesn't work. However, in the older age group, don't tell me what the number is. 30s in some of the literature, is it 35, is it 40? Some 50-year-olds, perhaps I met a guy from coast to coast, he may be the equivalent of a 20-year-old. Who knows, these numbers get made up. But in general, an older patient probably be doing more of a tenodesis. So it's confusing. confusing and it's still evolving. And it probably hasn't helped much, but that's the way it is.
Thank you very much, Mike. That was a great review of a difficult problem, and so